Healthcare. Hi, this is Barb Cochran. You're not going to see me, but you're just going to hear me. Welcome to the first lecture in our spring Geriatric Healthcare lecture series. As I said, I'm Barb Cochran, and I'm the Associate Director for the Northwest Geriatrics Workforce Enhancement Center, which is sponsoring this series along with the UW School of Nursing. This is the first of 10 lectures that will be held on Tuesday at the same time. I do want to let you know that you should have from your site coordinators a schedule of the lectures. For example, next week's is on aging and gastrointestinal health. You should also have information from your site coordinators that would include a profile form that we need you to fill out so that we can report this information to our funding agency and continue to offer this series. We do not need, we will not be reporting information by your name, but this just helps us keep track of things. You also should have information from your site coordinators that would be a link to the UWCNE website so that you can sign up for continuing education credits if that's something that you're seeking. We no longer have a separate handout. It's just a link to the website to get CNEs. Let's see, what else? These lectures are broadcast to the WWAMI region. They are also within about 48 hours archived on our Northwest GWEC website, and you can access them for free. You cannot get continuing education credit when you access them for free, but you also will have access to about 90 other great lecture topics that are also archived there. And the website for that is nwgwec.org. So please take a look. There's a lot of good stuff on that website. And today I'm really happy to introduce to you one of our more popular speakers. Stephen Thielke is a geriatric psychiatrist and health services researcher at the University of Washington and the Puget Sound VA Geriatric Research Education and Clinical Center, the GWEC. He's the GWEC Associate Director for Education and Evaluation, and he's going to talk with us today about depression. Welcome, Stephen.
Great. Thanks a lot, Barb. I'm thrilled to be here as usual. Thank you for all of you for taking the time to be here today. I hope you can all hear me. I'm guessing the audio is working out. Otherwise, please let us know through the chat. So really there's no way to make this topic fun or funny. It's kind of unfortunate. I was thinking about next week's talk about aging and gastrointestinal health. I mean, you could really have a good time with that. I just thought of a couple jokes that I had heard on that subject that I won't share because they're potty humor, but still you can make it fun. Whereas depression just is not a fun topic. It's depressing, basically. And I hope that we can still recognize the importance of it. And I'm hoping to convince you that we can all play a part in identifying older adults who are experiencing depression and also come up with some good ways of dealing with that. And part of the focus is really just purely clinical, you know, what the definitions are, what the categories are, what to do. But more importantly, I really hope to communicate some of the human experience of depression. And this is a tricky one because it's not something that you can empathize with necessarily. If you've never been very depressed, it's hard to imagine how someone could feel, or especially how someone could feel to want to take their own life. And we're going to talk about suicide at the end. So it's a little bit of a challenge and it requires a stretch. And I'm hoping that by spending some time going over the accounts of people who are more creatively focused and what their experience has been like, that I can communicate some sense of that. And hopefully we'll have plenty of time at the end for questions, so please feel free to type those in and we'll get to them at the end. Don't have any disclosures in relation to this. So what I want to do is first of all, talk about some of the common beliefs or misconceptions that are often proposed about depression in older adults, and then go through a definition of depression, then focus on what that human experience is, talk a little bit about how often and in whom it happens, and the interrelationship between depression and health in aging, and then to talk about some of the treatments, not so much nitty-gritty of medications, but more the global big picture of what works and what doesn't. And then really to spend a good amount of time at the end talking about suicidality, because I don't imagine you probably have had that covered much before, and it's important to have a good strategy for that. And we have an expert in that area here in the room with us. I know Mary is really very good. You can't see her on the camera, but I'm thrilled that she was here. Mary is a psychiatric nurse practitioner who has I've learned a lot from over the years. So some of the common beliefs that people may have about depression and getting older are listed here. So first of all is this idea that as you get older, you're just going to get depressed. Well, you know, you're getting on in years, your physical abilities wane, you've got chronic illnesses, your friends die, you can't do anything, your vision and hearing go to pot. Shouldn't everybody just be depressed when they get older? This is something you hear a lot. And it's mainly a sort of excuse. You know, well, they're 95 and they're depressed. Of course they're depressed because they're 95 and they're unhealthy. The other one is that depression is just like a bad day, a bad hair day like we all might have, and that really it's no different. And I'm going to try to show you how, in fact, depression is a very different constellation of symptoms than just being down once in a while. There's also an assumption along with aging that if you're sick, you're going to be depressed. So that if you've got illnesses, that depression is necessarily a cause of those. And I will show you data that points otherwise. And then specific to suicide, there's an idea people often have that if you ask somebody about suicidal thoughts, you're going to suggest to them that they might do it. Or if you ask them if they intend to kill themselves, they might say, I never thought of that. Maybe I should. When in fact, really, it's exactly the opposite. And I'm going to try to show how the most sensitive and reasonable approach to suicide is to bring it out in the open and be able to talk to people about it. And then finally, the idea that antidepressants somehow are the fix for depression, as if it was just a shortage of some chemical in your body, and then you put the chemical in and everything's better. In fact, it's much more complicated than that, and unfortunately, pills don't really work all that hot for lots of forms of depression. So that's the backdrop. And just to clarify, all these things are wrong in purple. And these are not what I'm saying. But I want to start with these thoughts because I sometimes fall into these traps also, and I want to be careful to make sure we don't together. So I want to go through some of the definitions of what depression is. There's a variety of scales that can be used, and what you'll see is there's some subtle differences between them, but the critical part of this is that it's a syndrome. These things go together, and when you see people who are depressed, it's unusual that you would have somebody who's fine in 3 or 4 of these and has terrible problems in the others. Usually when somebody has one or more of them and they fit a picture of depression, they've got them to all of them together. And that's one of the surprising things I found about psychiatry is that it's not like each of the problems just exists on its own, that psychiatric illnesses really fit together quite well and hang together. So according to the DSM-5, which is the kind of psychiatric manual for categorizing disease, in order to meet a diagnosis of major depression, you have to have 2 weeks or more every day, or almost throughout the entire day, for a 2-week period. Remember, 2 weeks. Got to have low mood or apathy. And then that would be feelings of depression or simply not caring. And then 5 of 9 of those symptoms involving sleeping too much or too little, appetite changes with weight change, trouble with concentration, not being interested in stuff, having low energy, guilty thoughts, not being active, having thoughts of death, and then along with that can go psychotic experiences, which are basically unreal experiences that people would have, like thinking that others are out to get them or hearing voices in their head. Usually the voices aren't bizarre things. Instead, they're negative thoughts that somebody might hear, like, you're no good, or you can't do it, or you should be dead. So you have to have 2 weeks or more of these every day, and then there has to be a clinically significant distress or a functional impairment that results. So it can't just be somebody who says they're feeling bad, but really it doesn't bother them or it doesn't have any effect on their life. It actually has to have a consequence for their daily living. So that's the official diagnostic criteria in order to make a diagnosis. There's a variety of scales that are used to assess the same issue. The scales are not diagnostic in themselves. So no matter what you scored on a self-report scale, that doesn't mean that you would necessarily have a diagnosis, although it certainly would be very suggestive. The first one is known as the Geriatric Depression Scale. And as the name tips you off, this has been structured to work best in older adults. And the way that they put it together is they started with a long list of questions and asked people who did and didn't have major depression how they felt about these things. And then they did a very big factor analysis to figure out which of them were best predictive of major depression. And you'll notice that these are different than the other symptoms about sleep, interest, guilt, and so on. And in fact, a lot of them focus on things that don't directly relate to the DSM diagnosis, like number 10, problems with memory. Memory is not mentioned in the DSM diagnosis. Feelings of boredom. And the first question about being basically satisfied with your life, which is also a little bit different than feeling depressed. So this tells us that for a geriatric population, for older adults, there is a subtle difference in how they might manifest depressive symptoms. And that it's not like somebody's going to come into your office and say, oh, I've got problems with sleep, interest, concentration, guilt, and I hear voices sometimes and my mood is low, so therefore I have depression. Instead, they may come in saying that they lost interest in things and they feel bored. So it's important if somebody identifies some of these symptoms, like staying at home or feeling bored or having memory problems, that you ask more about the other symptoms of depression. You can see on this the scale for categorizing folks. They're all yes/no questions. Up to 4 yeses is considered normal, although you have to scale it in reverse for some of them. So like, do you feel happy most of the time? The point you'd get would be no there, just to make that clear. So if you have 5 to 8 of them positive, that's considered a mild degree of depression, and then extending up. So that's a view into what a geriatric depression might feel like. There's another scale that's often used, especially in research studies, that maps a little bit better onto the DSM diagnosis, but not quite exactly. So this is known as the CESD. It's 10 questions, all from 0 being almost never to 3 being almost every day during the last week. So you can notice there's like number 6, fearful isn't one of the diagnostic criteria. Once again, just a subtle difference. I'm not suggesting that you have to pick one of these, but rather want you to notice that there's this big mashup of symptoms, all of which could occur together commonly in older adults. And that if somebody is depressed, and has a major depression, you'd expect them to endorse all of these. Probably the tool you will see the most in practice is the PHQ, the Patient Health Questionnaire, which was developed after a very lengthy and expensive process by a drug company to be used in drug trials, but now it's in standard clinical practice. And for a lot of systems, including where I work at the VA, they recommend that everybody gets screened with the 2-item PHQ, which you see here. So that's the 2 questions. One's about interest or pleasure, and the other is about feeling down, depressed, or hopeless. And then if somebody says that they experience these enough, so the total is 3 or more, then you would go to do the PHQ-9, which you will remember before, you have to have 5 of 9 symptoms. These really are pretty much just the DSM-5 criteria, all in a row. And they're all on a scale of 0 to 3, 0 being not at all, 3 being almost every day. And if you get a total score of 10 or more, that's suggestive of depression, although it's certainly not a diagnosis. So you could spend forever talking about the nuances of these scales. And I don't think you need to worry too much about it, except to appreciate that there's different ways of looking at depression. And it's not like you're dealing with an absolute right or wrong answer as to whether somebody's got depression or not, but that usually people report a variety of symptoms that fit together. So if somebody has symptoms of this type, you want to just keep a few other things in mind that overlap with depression. Bipolar disorder is a psychiatric condition in which there are episodes of depression and then also episodes of mania or hypomania, which are, to put it simply, kind of being the opposite of depressed. So if somebody's manic, they spend too much, they get hypersexual, talk a lot, don't need to sleep, and usually get into trouble, either with the law or from being psychiatrically hospitalized. It's kind of no mistake when somebody's really manic because they're just so revved up and grandiose. There's also bipolar II disorder where people don't get all the way fully revved up, but they have some of these symptoms. A lot of times people will just feel very productive, like they need to sleep less and they get a bunch of things done for weeks on end. It's important to identify these because the treatments are substantially different for bipolar disorder compared to major depression. And you may think or have heard that bipolar disorder isn't going to be an issue in older adults, but in fact, you can have a first bipolar episode anytime in your life. Once in a while, we'll see people in their 70s or 80s who seem to have their first manic episode, which is just always kind of bizarre to me. I don't know if you've seen that before, Mary, but...
Once they are losing control.
Okay.
I haven't seen any first episode.
Nuance it. Okay. Yeah. So so just be on the lookout for that. Also, depression can overlap with the inability to process information. So if somebody really does have the beginnings of a cognitive impairment, they can seem to be depressed because they're just not interested and they don't have the interests that they did, and they can't pay attention like they used to. Usually you don't have to look too far to separate those out. In later life, people oftentimes lose loved ones. And it's a very natural reaction to have a lot of these symptoms if your spouse of 50 years dies. You can imagine the change that brings, and you'd expect someone to have problems with sleep. They could lose weight. They may not be as interested in things they were. So the dividing line between what we call grief or bereavement compared to major depression is whether somebody still wants to be alive or not. So if somebody is in an episode of bereavement and they say they just don't want to be alive and are thinking about suicide, then that would constitute as being a major depression. Otherwise, we try to keep grief separated because it's assumed that if you hold on and wait it out, that the grief usually gets better. Adjustment disorder is another condition that overlaps with depression. This is a psychological response out of proportion to a stressor. So something stressful happens, within 3 months you get symptoms of depression or anxiety that are more than you'd expect, but it does not meet full criteria for major depression. And then lastly, there's one called dysthymia, where you have some but not all of the symptoms of depression on a frequent enough basis. So you might have feelings of being depressed every other, every third day, and this goes on for a long period of time, but you never have all enough symptoms during a 2-week period. So this is really kind of nitpicky, but it's just to suggest that if somebody has feelings of depression, or if they're showing some of the symptoms, you want to make sure you don't just rule out other causes, that there may be some other good reason for it. I think I have not explained depression really at all when you think about what the patient's experience is like. When I see patients who are very depressed, usually they'll have trouble articulating how they feel, but when they do, it's with some very powerful metaphors, like swimming in concrete. I remember a patient told me that I just feel like I just can't do anything. Or people say they couldn't think their way out of a paper bag, things like that, just being stuck. And these are quotations from a book called Darkness Visible by William Steeren, a novelist who suffered from major depression. I'm not going to read these aloud to you, and I hope if you get bored later in the talk or on your leisure, you can read these. But they're very strong ways of explaining what depression is that are different than the purely clinical one. It's not just like, well, I'm depressed and I had trouble sleeping and my mood was down and I had some feelings of guilt. This is really something that takes over your entire body, that like saps you of all your human will and your strength, and almost makes you paralyzed. And he even characterizes it as being almost beyond recognition. I'm guessing when he was writing this material about depression, he probably wasn't as depressed, and he was trying to project himself into what the feeling would be like. And he says that your intellectual capacities can't even really get around this. It's hard even for somebody who's extremely articulate to characterize what depression is about. And I like how he takes on even the word depression, calling it like this slug that's made its way through the language, and by its very insipidity, preventing us from appreciating what the horrible intensity of the disease is. So this is not just a subtle thing for people who experience it. It's a very big deal. It takes over yourself, and it's a challenge to get back out of it. I want to touch quickly on an analogy that a lot of people use, which is pain. And depression and pain have a lot in common, and it's hard to know where one starts and the other ends. The physical experience of pain in our bodies overlaps a lot with the experience of psychic pain. They've done some fascinating experiments where they'll put people in MRI scanners and either like pound on their toe to cause some physical pain, and certain areas of the brain light up. And then they'll also have people play a little game where they're, appear to be getting along with everybody and doing all right. And then all of a sudden the game says, you're a loser, nobody wants to be your friend. And exactly the same areas in their brain light up as with physical pain. So that our body's capacity to separate out physical and mental experiences is not very good. And when people think about the experience of depression, they very often invoke this idea of pain, as Steeren does, that it has a quality of physical pain. And then I came across by accident this line from Bob Geldof, who talked about how painful the experience was when his wife broke up with him. If you like images instead, I always find this one really kind of descriptive of what it would be like to be the little orange guy and have everybody else doing okay, and you're just stuck on the outside. for humans, it's really important to be a part of a group and to fit in and do okay. And if you get cut out from your group, you're going to be in big trouble. So that's a kind of a lengthy digression, and I honestly can't do it justice, but I do hope that you'll get a chance to think a little bit more about what this experience might be like. And as I mentioned at the outset, it's very difficult to project what it would be like to be this depressed if you're not that depressed. You can imagine what it would be like if it was 150 degrees in this room, or if it was freezing cold, but that's all very hypothetical. And until you're really living it, you don't know what it's like. All right, so I want to challenge quick in a few bits of data, this idea that as you get older, you're going to be more depressed. This is research that we did using the cardiovascular health study, which is a study of 5,800 community dwelling older adults who filled out annual surveys. And we categorized them in terms of their mental health status and their physical health status. So they were either healthy or sick based on their self-rated physical health. The question, how is your health excellent, very good, good, fair, or poor? And then we categorize them based on their degree of depression using that CESD score. And they could be in one of the 4 boxes that's created, or we looked at the effect of mortality also. So that clear, one of those 4 boxes, or dead. And if you've got these 5 states, then you can have 20 possible transitions between them. And what we were interested in is how likely are people to go in or out of these states? If, for instance, being sick made you depressed, then you'd expect people who were sick and non-depressed to go into a state of being sick and depressed. Or if being depressed made you sick, it would be the opposite. And then also you can look at the likelihood of death in these various conditions. And what we're primarily trying to do is figure out what the effects of age are. So what you see in these graphs, the x-axis is the age of the participant, and then the P there is the probability. So on the upper left is the probability of becoming depressed as you get older. And this is kind of funny, as if you're in the sick group, as you get older and older up into your upper 80s, your likelihood of being depressed doesn't go up, and in fact goes down a little bit. But the difference is tiny. And the likelihood of becoming depressed among the healthy is quite a bit lower, but it doesn't go up much with age either. So then we looked at the probability of remaining depressed, which would be staying in your category. And it looks like those probabilities really don't change much either with age. So no matter how old you are, your likelihood of remaining depressed, if you are depressed, is pretty stable, but it's also quite high. So you can see that, like if you're sick and depressed, your likelihood of still being depressed the following year is above 60%. And if you're healthy and depressed, your likelihood is about 50%. So those are not encouraging for people's ability to bounce back. And then the real big difference you see across age here is that blue line on the bottom, which is the probability of somebody who's depressed returning to a non-depressed state. And among the healthy, as they get older, their likelihood of becoming undepressed really falls off. It's less than half the likelihood at age 85 than at 65. So the big difference we see with age here is that as people get older, their likelihood of bouncing back from depression gets lower. It's not like they're much more likely to become depressed as they're older. It's just that once they're in a depressed state, they're not as likely to go back. And maybe part of it has to do with the fact that everybody's just like, well, you're old and depressed, and we're not going to do anything with you. I'm not saying this is inherently the case for everybody, but that in this group of people, at least, the older they got, the less likely they were to get better. Surprisingly, among the sick, it wasn't as big of a deal. So people who were healthy and younger were relatively, had a good chance of bouncing back, but as they got older, that dropped off, whereas the people who reported themselves as sick had a pretty low likelihood throughout. So here's another very unexpected result about the risk of death, that for people who said they were healthy, being depressed increased their likelihood of dying by about 1.5 times. And it got a little bit less likely through age, but it was pretty constant. Whereas for people who were sick, it didn't seem to affect their risk of dying at all. And in fact, it almost looked like depression may be a little bit protective. There were other ways we ran the data that suggested that being sick and undepressed put you at greater risk of death than being sick and depressed, which suggests that it may be some kind of coping mechanism that people have that helps them deal with their condition. So all of this is a lot of fine slicing and dicing, but I want you to remember that the key take home is that as you get older, you're not that much more likely to become depressed. Instead, what you're at risk for is remaining depressed, and that's what we should be on the. That's where our alarm should be out for. Is people who are older and depressed. We've got to figure out ways to get them better. It's not like our efforts would be wasted, because as that data shows, once somebody is not depressed, their chances of bouncing back into depression aren't that great. So the real challenge seems to be that aging is associated with remaining in a depressed state. I hope all that makes sense. I've tried to figure out other ways to explain it with analogies or a little more directly, but unfortunately, it's a little bit nuanced. So anyways, please give up the assumption that just as you get older, you're going to be depressed because you're old. All right, so let's talk about treatment. And things get complicated here. It would be great if we were dealing with that simple model of like a deficit, where the problem is you don't have enough of this chemical in your brain. We give you that chemical and you're better. In fact, it doesn't work like that. You'd think that if somebody's a little bit depressed, you'd give them a little bit of treatment that would fix them. Or if they were really depressed, you'd give them a lot of treatment and that would do it. Kind of like everything else in life, where you've got a little nail, you're not going to hit it with a huge hammer, and vice versa. Unfortunately, things don't work quite like that. The first observation that people made about 10 years ago that's really fascinating is that antidepressant treatments don't really work for milder forms of major depression. So the x-axis is the score that people had on a Hamilton Depression Rating Scale, which is used in research. It's basically a marker of depression severity. The cutoff is about 20 usually for having depression or not. And then the y-axis, the little dots, the white ones are the observed changes in that score based on, if the white ones are placebo and the dark ones are antidepressant medication. And what you see is that the antidepressant advantage over placebo, what you would consider to be the active effect of the drug, doesn't really kick in until about 25 on the scale, which means that for people who had more mild forms of major depression, they're really not getting much from the drug at all. And that the big differences between drug and placebo are only for severe cases of depression. So this is a challenge, because we use the cutoff of 20 or having a major depression as being the point at which you would say, well, this person deserves a treatment, and if we treat them, they have a good likelihood of getting better. In fact, it appears that maybe only the folks who have rather severe symptoms are the ones who are going to benefit from medication treatment. So for mild depression, even if it meets diagnostic criteria, there's really no difference between treatment and placebo. But for major depression, it looks like the more severe the symptoms are, the further you get to the right, the bigger the difference is between placebo and drug. And there really is no clear dose-response relationship. So what you'd expect if it was a dose-response relationship is that those two lines would start off about the same, and then they would separate out consistently throughout. But that, in fact, they end up crossing there and don't show much difference below 25. All right. So I've showed this slide when I was talking about deprescribing, and I think it's absolutely fascinating. This is the percent of people who responded to antidepressant drugs and to placebos across a 30-year period, from 1980 to 2010. Across each one of the dots is a different study that was done of various antidepressant drugs. And when they plot the trend, it looks like antidepressants are becoming a little bit less effective over the years, whereas placebos are becoming more effective over the years, to the point that they almost overlap now. So this is really a difficult observation if your only tool for helping people with depression is antidepressants, because it suggests that, first of all, you're probably not going to be giving people that much advantage by giving them a medication. And secondly, that your overall response rate with medications is still only going to be about 50%. So if you had other things in your life that work half the time, you assume that's really not so hot. You take your car to the shop and they say, well, we've got a 50% chance of fixing your engine. You wouldn't be very impressed. Or if you're buying a new phone and, well, it's got a 50% chance of working, you probably wouldn't invest in that. But this is the standard of care that we have for depression, and that really is a problem. And I'm going to give some data about how we can do a better job with treating depression. But it's important to remember the placebo effect. So when you really think about what the dose response curve is for antidepressant treatments, with dose being along here, like a higher dose is to the right, and then the response would be the improvement in depression on the y-axis. Well, you could say, well, it could be a straight line, or maybe it's this S-shaped curve, or maybe a shifted S-shaped curve. And after thinking about it for a while, what you realize is that all of these lines are completely wrong, because if you recognize that placebo effect, a dosage of 0 of active medication really has a very good response. So the real dose response relationship between antidepressant treatments and response is more of a hazy straight line that does not show any remarkable or consistent effect. I wish I could stand up here and give you a lot more concrete detail about, this drug works at these doses and therefore you should be using this, this, and this. But the more I read about really what the data is for antidepressant use, the less convinced I am that there is any magical dose that is going to help people consistently. And that really what we're stuck with is the fact that even the best of treatments, whether placebo or drug, are only going to have a totally positive effect in about half of the people. So then what is the problem? Like, why don't our treatments work? And people have spent a lot of time looking into this, and they've found some pretty big system level barriers. And that's what I want to focus on, because this is where we can really all play a part in making sure that people get the sort of treatment that will help them. So if somebody's got major depression and they go to treatment, about 30% of them never go to follow-up, even if they've got a diagnosis. Of those who do follow up, about 25% only go to one appointment. And then of those who consistently follow up, about 30% of them don't get a significant result. So if you run all the numbers and look in a usual care setting, like a big healthcare system, to see what percentage of people, older adults with major depression, have a total remission at a year, it's only about 19%, which is really kind of dismal. And yet at the same time, about 30 to 40% of older adults are on an antidepressant, which when you do the math doesn't really work, except if you realize that the pills aren't fixing the problem. So we're missing an opportunity. I hope in the way I presented depression, you will appreciate that it's a treatable problem. It's not something that's going to be there forever. Unlike dementia, which is a progressive neurodegenerative condition, depression can be treated, oftentimes remits on its own, but we're just not doing a great job of treating depression. I added this link at the bottom. I apologize that this wasn't on the slides I sent out because I just came across this today. A friend of mine sent it to me. It's a government publication from AHRQ. So this isn't some fringe organization. This is the US government. And they discuss the risks of antidepressants in older adults. It's a really, really interesting article. They did a systematic evidence review, and they pointed out some of the really critical side effects that are common in older adults and how that can impact the type of care that we give, which argues yet again for extra care with what we're doing. So it's not like these treatments are entirely without risk either. So hope if you can't write that down and you want a link to it, just email me and I'll send it to you. So let's talk about then you've got somebody who's an older adult and they have depression. Why wouldn't they get treatment? The department chair in psychiatry, Jürgen Unitzer, is a geriatric psychiatrist who developed a lot of really valuable models for dealing with geriatric depression. And what I'm going to show you here is from a trial he did called the IMPACT trial, which is a collaborative care intervention. And when they talked to a lot of older adults who had depression and tried to figure out why they weren't getting the type of treatment that would help them, they found there were a lot of common assumptions. We talked about some of them, like that it's just a part of normal aging, that if you're older and your spouse has died or your friends have died, of course you'd be depressed. People don't want to acknowledge that they have any form of mental illness. So even admitting that you have depression could make you feel crazy. And a lot of times people just said they didn't know what happened. You know, things were going along all right, and then all of a sudden they're very depressed, and it's hard to know what to do with that. It also became very clear that in primary care settings, providers and everyone really wasn't, the system was not well adapted to identifying or dealing with depression. So you've got a 15-minute visit and 14 health problems to deal with. Depression's going to be pushed down the list. People who start treatments and they don't work just end up staying on them. As I mentioned, about 30 to 40% of older Americans are on an antidepressant. And then there's just not much access to mental health. There was a researcher in Texas who videotaped primary care appointments with older adults, and the total length of time involved in diagnosing depression, like asking all the questions to make a diagnosis, and prescribing a medication for depression. Anybody want to guess how long that process lasted in primary care? How many? Months? No. So like during the actual visit, so you've got a primary care appointment that's 20 to 30 minutes long. How much time did it take for the providers on average to ask all the questions about depression, make a diagnosis, and start a treatment? It was 2 minutes. So they're busy, they're pressed. So how are you feeling? Oh, your mood's not good? Oh, you sleeping all right? Nope. Okay, here, why don't you take this Prozac and go out the door? So it's a big challenge. I don't want to make it sound like they're doing a bad job, because they've got tons of other priorities, but the system they have is not going to spend the time or the effort in order to find people who have depression and then really give them what's going to help them. So what then really works? So when they put all this together, they recognize that antidepressants may have some effects, but when they talk to patients, most of the patients preferred psychotherapy to medications. And they used a treatment called problem-solving treatment, PST, that's focused on getting people to identify what their goals are and how they can accomplish them. The T is not therapy, importantly, if you're looking into this. It's a problem-solving treatment. Doesn't have to be a high-level expert who does it. So the best example I've heard is the guy who feeling depressed, he's widowed, and in the PST treatment, they'd say, well, what did you used to do for fun? Oh, I used to go swimming. Why don't you go swimming now? Well, I don't have a swimsuit. Okay, well, how about you get a swimsuit by next week? And they call him up in a week. Do you have your swimsuit? Yeah, I got the swimsuit, but I don't have a pool to go to. All right, let's find you a pool. They'd call around and find a pool for him to go. And then, okay, now I got the pool. Have you been there? No, I got busy. Okay, well, let's get you to the pool. And so it's just sticking with the focus on what the challenge is and how to deal with it. And this guy is a great case. It's an actual case. And within 3 months, he was really back to himself and feeling quite good again. The patients who are part of this problem-solving treatment sometimes referred to the person who did this, the care manager, as sticking to them like a cheap suit. You know, they just wouldn't let them go and would keep hounding them until they started taking action to get themselves better. So this whole model that I'm talking about with problem-solving treatment and having somebody else call up a bunch is known as collaborative care. So the patient works with the care manager and the provider to figure out what type of treatment they would like, whether it's medication or psychotherapy. And then the care manager calls them up on a frequent basis and asks them how they're doing and what steps they've taken. And the primary care person really is kind of in the background. They'd prescribe medications based on some suggestions, but they're not the responsible agent. And then even further in the background from that is a consulting psychiatrist who looks over all the people's scores on their symptom scales and makes a determination as to whether to make changes. The tracking of outcomes is important. In this approach, they would use the PHQ-9, measured about every week. If somebody doesn't get better in 6 weeks, you'd say, well, our treatment's not working, let's try something else. And if you use an algorithm to do all this, you really get much better results than in usual care. So this is the original study, which got a lot of press. The people in care intervention were about twice as likely to remit for their depression as people in usual care. So certainly not going to fix absolutely everybody. And a lot of the poor response was because people dropped out even from this program. But what I want you to appreciate and think about is that if you want people to get better from depression, the answer is not an antidepressant handed out by a primary care provider or a specialist. The answer really seems to be a holistic wraparound type program that coordinates care between a lot of various players, and in particular has the role of care manager. I assume you'll be hearing more about collaborative care for other conditions also, but that seems to have been a very effective model. All right, so that's the primary content just about depression, and I want to spend the next 20 minutes or so talking about suicide and how to approach it. Wherever you work, you may come across people who have suicidal thoughts. And what I want you to be able to do is don't freak out, mainly. It's probably a good lesson for anything in life. Don't freak out. If you learn that somebody has thoughts of killing themselves, don't run away from it, or don't say, don't do that, whatever you do, stop. and also not to baby them, assuming, oh, must be so sad, you poor thing. Instead, I'm going to try to sell you on the idea that you can have a reasoned and productive conversation with them that will assess what their risk level is, and also give them some useful approaches for other ways of dealing with their thoughts. So suicide is, in fact, a public health crisis. I assume you've seen this in the news. It's the 10th leading cause of death for Americans. For people between age 10 and 34, it's the second leading cause of death. 10 to 34. So for young adults, there's not many other things that kill young adults, and that's it. There's for older people, it's not as high on the list, but certainly quite common. And the other statistics that I just looked this up to make sure is recent. There's 50,000 suicides in America last year, that's a lot of people, which is twice as many as there were homicides. So twice as many people die of suicide than homicide. And there were 1.5 million suicide attempts. So it's not like people go out and the first time they attempt suicide, they're going to die. In fact, it's quite more common for somebody to have made multiple attempts. So a common thing, it's unpleasant topic, certainly, and can be quite difficult, but it's really important for us to know about it. So this graph here, which is a little bit old, but the data is still pretty much the same trends, shows the breakdown of completed suicide rates by age and race, black and white. So what you see is that the suicide rates are extremely low for Black women throughout the lifespan. For white women, they're a little bit higher in midlife and then go down a little bit. For Black men, rates are higher young in life and then later in life. And the group that has by far the highest rate of suicide is white men who are older. So just that sheer number of suicides after age 65 really is comprised mostly of white men. So if you're going to remember one group that's at biggest risk for suicide, it is older white guys. As I was trying to explain about depression, it's hard to imagine yourself being depressed, and it's even harder to imagine what it would be like to be so hopeless that you'd want to commit suicide. There's a lot of theories about why people might do this, and none of them really can make sense of it, obviously, because it's not really a rational decision. The best explanation that I've heard from a psychiatric perspective is it's not so much a sign of how sad or depressed someone is, but rather they see it as their best way of solving a problem. It's just a bad problem-solving approach. Well, this is impossible, that's impossible, nothing in my life is going right. The only logical way to deal with it, given this information, is to not be alive. And if you recognize that suicide is probably in some way or other just problem-solving gone awry or bad problem-solving, that gives you more of a way to deal with it, because you can help people solve their problems instead of thinking of it as being a sign that they're just so flat out sad that they can't live. There's also other theories that suggest that being suicidal is like having a negative quality of life. When people think about quality of life measurement, like 0 is the worst quality of life, 100 is the best quality of life, where 0 is like dead. And you assume that people would take action to get their quality of life better, like they would do something in order to feel better. If you think about suicide, somebody would take action in order to be at a state of 0 quality of life, which is just also bizarre, but I think that fits somewhat with how patients think of it, that they would be willing to plan and take steps in order to have a quality of life of 0. So there are some specific warning signs. Most of these are pretty self-explanatory, and there's no single thing that will tell you somebody's at risk for suicide. They've done all sorts of studies looking at completed suicide, what's known as psychological autopsy, to see if they can sort out who was or was not at risk for committing suicide. And these factors show up, but there's no single fingerprint or blueprint that would tell you the people who are going to be at risk. But if you hear that especially if somebody has had thoughts of killing themselves, that's probably the single biggest tip-off. And that's the thing you have to know about, is have you had thoughts of wanting to hurt yourself or kill yourself? And then the other feelings go along with it. And I'm gonna, these are the specific risk factors that on a population level make somebody most at risk for suicide. Back to the pain theme, and this I found very interesting, was work by psychologist Edwin Schneidman, who examined all of the suicide notes for Los Angeles County for about 10 years. And his conclusion was, as you can see there, that pain is the basic ingredient of suicide. That people who want to commit suicide perceive themselves as being in this unbearable misery, and that they're getting these constant signals that psychically they hurt and they hurt and they hurt, and their only way out of it, their only escape, is not to be alive anymore. So this also, I think, is a very different framework than you might expect if you just think about, well, why would somebody want to kill themselves? Well, it's because they're so depressed. In fact, it's probably more like they feel like they hurt bad and they feel like they don't have any way to solve their problems otherwise. And sure enough, when people have studied on a mathematical basis what makes people more or less likely to commit suicide, you can see that being depressed has a risk of about 4 times higher likelihood of attempting suicide or completing. This is completed suicides, but pain was just a little bit higher. So this is after you control for everything else. It seems that pain really probably is a core element. So just something to be on the lookout for. If somebody talks a lot about how much they hurt inside, that clearly is not a good sign. So what do you do? As I mentioned, don't freak out. It's probably the best first thing. Don't jump to conclusions about somebody's risk for suicide. You can't know unless you ask. So you got to ask the question. And what you appreciate after doing this a couple times, or if you work on a psychiatric unit at tens of thousands of times, is that people will give you an answer, and usually you can trust them. There is no evidence whatsoever that asking people about suicidal thoughts will encourage them to commit suicide. In fact, it's the opposite. So just that one you can put out of your mind completely. There's other things that you might be worried about asking about that, you know, would give people ideas, but this is not one. Yeah. Plan, exactly. Great question. So we'll get to that on the next slide, but absolutely, it's good to have a framework. So the way to start would be to say, like, you know, do you ever have thoughts of not wanting to be alive? Do you ever have thoughts of taking your own life? I'm avoiding, you know, writing it out word for word, because it usually works better if you kind of build it into the conversation instead of as if you're reading it. And then you'd ask, if they say, well, yes, then you say, well, do you ever have actual plans that you've followed through on? Do you have access to lethal means? So we'll go through that on the next one. That's a great question. So then the question is, how worried should you be? And really, your basis for worry shouldn't be your assumptions. It should be what the patient tells you. So if they tell you, I'd never kill myself, I love my family, I wouldn't do it even though I have had thoughts of not being alive, then that's relatively assuring. Whereas if they tell you, oh yeah, I've been thinking about it for 3 months and I've stockpiled pills, that would get you very concerned. And also you can look at the previous behavior of the patient. So if somebody's never attempted suicide, that's a reassuring thing. But if they've had multiple suicide attempts, that's very concerning. Suicide is still a relatively rare event, and suicidal acts, even though there's 1.5 million of them in the US, don't happen all that often. So there's no perfect way to predict, but we certainly can assess risk based on what people tell us. And I just want to point out that there's a subtle difference between error in judgment and malpractice. So error in judgment is where you'd see somebody, you would say, I assessed them, I asked them these questions about suicide, they said no, I consider their risk to be low. Then the person goes out and say they killed themselves, and it would look like you had missed something, when in fact you had just made an error in your ability to predict the future. Whereas if you see somebody and they tell you, I'm depressed, and you write down, they were depressed, and then they go out and kill themselves, that would be malpractice, because if you've got somebody who seems to be depressed, you should be asking them about their thoughts of not wanting to be alive. So that's just a little reminder to you that it's much safer to ask and to document if you've got somebody who is showing any signs of depression, rather than just wishing it would go away. And that if you make a mistake, but you've documented your thought process, that's not going to be a problem for you, because it was simply an error, or not even an error, but an inability to deal with uncertain information. All right, so in psychiatry, every time we have an appointment with a patient, we assess suicidal thoughts. I'm not saying you have to do that for, you certainly, if somebody's doing just fine and you're seeing them in another clinic setting for their diabetes, you don't want to first thing ask them, you're thinking about killing yourself? But if somebody has symptoms of depression, or if they're reporting those types of symptoms that we talked about before, it's really important to assess suicidality. And you can do this in any way that's comfortable for you, but just straightforward questions. Do you ever have thoughts of hurting yourself or killing yourself? And if somebody doesn't, let's say, nah, I don't, and then you can move on from it. But if they say, yeah, I do, then you'd want to follow up and ask about their intention. Like, do you think you'd act on these? And if so, have you thought about how you would do it? And then to figure out if they've got lethal means that they could follow through on, especially guns, which that figure of the white men at risk, most of those are by guns or by pills. And then if you find that someone is at risk, then you turn for help. There's a lot of options for what can happen. Here in King County, for instance, there's the designated mental health professionals who would come out and evaluate the patient, or even do home visits, a home assessment, welfare check, and they will determine if the person is an imminent risk to themselves, and if so, they will have them placed in a psychiatric facility. Or if you're really worried, like somebody says, yeah, I've got my gun at home and I'm going to kill myself today, then you call the police, which is also an all right thing to do. So, but if you ignore all this, that's when you get in trouble. So I understand that this is outside of a lot of our comfort zone, and I've asked this question thousands and thousands of times, as has Mary, and it's easy to do after you practice it, but the first couple dozen or even 100 times it feels awkward. So I'd encourage you, if you get a chance, to just try it out and get used to asking about suicidality. The other important things, if you're documenting interactions, you want to make sure you include this, and then include, as I said, an assessment of risk. So is the risk level low or high? And if you say it's low and something happens, then you've not predicted the future, but you've still done a careful job. And then in terms of what to do with the patient, all I've said so far is really about like protecting yourself from documentation or calling for police. But what do you say to the person when they say, you know, I don't want to be alive, I can't take this anymore? And here's where I have I hope or I expect is probably a little bit counterintuitive. One approach would be to say, "Oh, poor you. You know, that's terrible. You're so depressed. How are we going to get you undepressed?" And I don't think that's all that productive, because then it kind of babies the patient a little bit. And instead, I encourage you to try to get them to doubt that this would be a good decision. Really to focus on the problem-solving part of it. And the people who are good at this, who are like professional suicidologists, sometimes come out and are really blunt, like with the, you know, boy, that sounds like a really dumb way to deal with your problems. That seems like a really poor problem-solving approach. And then the patient's like, what are you talking about? But then that gets them thinking about how they can solve their problem instead of why this might be a good idea. So you first can validate their feelings, you know, point out that it's important, that their life is important for you, but then you really get to the nitty-gritty of, well, you got this problem, how are you going to deal with it? You thought up that solution? That one doesn't sound so good. That sounds like that would be pretty disastrous, like one of the worst decisions anybody could ever make. So let's talk about other options for how you can deal with this. And there's some data that's kind of very compelling for people, even if they're not thinking straight. And you can point out that we don't know what happens to you after you die, you know, but there's a lot of people around the world who believe that if you kill yourself, you're going to suffer eternally. What's the chance of that? You know, even if it's a small chance, are you willing to risk it? And maybe things are better now than they would be if you killed yourself and you get punished eternally in the afterlife. You know, you don't need to provide a lot of details, but it kind of gets people scratching their chins. The other very important statistic is that the loved ones of people who commit suicide suffer enormously, and their children are at higher risk for suicide if they commit suicide, which oftentimes really gives people pause, like, whoa, if I kill myself, then my kids are going to be at risk for suicide too. Maybe I shouldn't do this. So that one, there actually is data. You know, even if we don't know what happens to you in the afterlife, we do know that the consequences of suicide on people's families are very big. So again, the general theme is, in any way you can, to get people who are having thoughts of this type to step back just a little bit and to feel some doubt about what they're doing, and to think about other ways of dealing with their problems. And then there's a lot of process after that. Certainly, it's not like that just fixes the problem, but at least that gets things in the right direction instead of being completely at an impasse. So if you had questions about suicidality, please type those in. Wanted to summarize all of what we've talked about today. So depression is a syndrome, a constellation of symptoms with a very powerful human experience. It's not just having a bad day. It's not a part of getting older. It's not part of normal aging. Certainly it's associated with people being sick or having losses in life, but it shouldn't be expected. So if somebody's depressed, don't just chalk it up to them being older. Depression is a treatable condition, but our current health system doesn't do a very good job of treating it. And the treatments that really seem to work are ones that engage the whole person and involve a designated agent, especially a care manager, who can ensure that the patient gets the types of treatments they need. And then in terms of medications, just be on the lookout for those, because there's not a huge amount of data that they fix the problem. And especially around dosing, it's not like a little depression means a little antidepressant. And finally, I encourage you to be ready to interact with patients who have suicidal thoughts, because the more you can do to help them deal with their problems, the better it will be for everyone. So any questions, just email me, or that's my office phone number. And I think we've got some time for questions.
Okay, so is it possible that all of the drugs that are working their way into our food and water supplies through people flushing their old meds down the toilet is playing a role in the perceived ineffectiveness of antidepressants?
Wow, that is a great question about possibly if these drugs actually have made it into the water supply, if that might reduce their effectiveness. You know, I haven't seen the latest data. My guess is that probably there's minimal direct human exposure. The concern has been mainly about mammals and fish that are exposed to runoff. You know, fish, especially if they get exposed to SSRIs, have showed neural tube defects or other changes in their development. But those aren't the type of fish that people usually eat. So there was a study looking to see if just people in general from drinking water and eating regular diet would be exposed to drugs that people flush down the toilet, and it didn't look like that was much of a risk. But that is a great question, and you know, certainly maybe a reason why we're getting different effects over time. There's another maybe clearer explanation about this, which is that when drugs are first marketed, they seem to work better. And there's a saying that you should use the pills when they're new, because they're going to lose their effectiveness over time as they get less heavily marketed. Great question.
Is it even ethical to prescribe an antidepressant without thorough evaluation of the patient, given the warning in PDR and circulars that the drug may produce suicidal ideation and precipitate suicide? This seems more common in teens, but occurs in all age groups, usually with SSRIs.
Yeah, great question about prescribing safety. Oh, yeah. Yeah, so there is evidence, especially in teens, that after starting antidepressants, the risk of suicide goes up. It's hard to say exactly. It's probably about a month or two period. There's less evidence for that in older adults, but certainly for kids. And that really speaks to the importance of frequent follow-up after initiating prescriptions. That you can't just say, oh, here's your pill, good luck to you, I hope you get better. That you really need to have very frequent appointments on the early part of the treatment process. Yeah, and as the FDA warning is there, so it's not like this is just a hypothetical thing. It's something that everybody should know about. Great question.
Do we have any questions in the room?
Yeah.
In the inpatient setting, older adult comes in with depression, suicidality, and you choose not to give an antidepressant, then will insurance still cover? Great
question. So the question was, if in an inpatient setting, an older adult comes in and they don't want an antidepressant, or they've tried them before, and it doesn't work, will the insurance cover it? Boy, that's a challenge that has to do more with the pressure to get people out the door than necessarily looking at the treatment responses. So I also didn't point out some of the subtlety with antidepressant use. When you look at the time it takes after starting an antidepressant and when people start saying their mood is better, it's about 6 weeks. So it's not like somebody takes the pill, they get suddenly better. This new medication, ketamine, I don't know if you've heard of that, or S-ketamine, is supposed to have a big advantage that it works rapidly. Unfortunately, the effect goes away. S-ketamine is not FDA. It just got FDA approved in early March. And so there may be more push to using these type of fast-acting medications. But the other part of treatment I didn't talk much about, but since you brought it up, is electroconvulsive treatment, also known as shock treatment, that suffers a lot of bad press, but it is in fact the most effective treatment we have for major depression. Really can be administered very safely now, does not have long-term consequences on your memory, and it really can bring people back from serious depression in a short amount of time. I don't know about the insurance part of it, other than to say that I've been there, and it's a challenge if you have somebody in the hospital and you're trying to get them better, and the insurance says, well, why aren't you throwing a bunch of pills at them? So, yeah, great question, Mary. Yeah.
So regarding memory, I actually have a client who is trying to determine how much the depression is actually impacting memory because the scores are kind of low. And so I'm just wondering, in terms of, are there studies or anything that you can recommend to look into a little further to better understand how depression does impact memory?
Great question about how depression impacts memory. And the case you brought up is somebody who seems to be depressed and also has low scores on their MOCA. Okay, so serious depression, right?
Really low, or is there something going on because she's 50s?
Oh, so younger, right?
Like dementia level scores, and trying to determine, like, is it the depression that's feeding into this? How long do you wait for your test? And it's just kind of
great question. So this is somebody in her 50s who is doing very poorly on the cognitive testing, but also has severe depression. So in the dementia talks, we focused a little bit on the idea of pseudo-dementia, which is that you can be so depressed that you become demented. And I suggested there that there's no evidence that pseudo-dementia exists as an actual construct. So dementia is a progressive neurodegenerative condition. Like, you've got changes at the cellular level that are causing your brain cells to die. Whereas our model of depression is it's something to do more with neurotransmitters, but it's not like your brain cells have died. So it just doesn't make sense from a model perspective that if you're depressed, you're going to start this process where your brain cells die. At the same time, why would the original idea of pseudo-dementia come up? And it's because there were a lot of people who seemed to be depressed and have cognitive problems. And it was thought, well, the depression caused the cognitive problems. So a guy in New York, George Alexopoulos, one of the grandparents of geriatric psychiatry, did a long-term study where he took patients who had cognitive problems and depression and tracked them over time. And the vast majority of them were on their way to dementia. So it was either maybe the depressive symptoms were a manifestation of early disease, or they just happened to have both at the same time. But it's not like they were depressed and therefore they seemed demented and then they got the depression treated and they bounced back.
So it makes sense that for the neuropsychological evaluation,
yeah,
rather than just saying, oh, let's just see how the depression gets better and not keep prolonging.
Exactly.
Right now, it's prolonging stage. I'm trying to push to say no.
Yeah, that's a great idea to work it up. And even when people are very depressed, and you give them testing, if you can keep their energy level up and their focus, cognitively they can answer your questions, even if they're showing some signs of not wanting to try that hard on tests. So even when somebody is in the grips of a major depression, you can usually conduct neuropsychological testing relatively effectively. Great question there too.
I don't have any more in the chat box. Any more questions here?
Yeah, all right, one more here.
One more. So looking at people who've been on antidepressants for a long period of time, and maybe have, not maybe, I'm thinking specifically of people that I know clinically are in situations who have tried many different antidepressants. You're on it for a while, and then it doesn't work as well. You get to different ones and so forth. So many years on this. Is there any evidence to look at the possibility of it might be better to actually start trying to wean them off of that and looking at different ways of addressing it.
Absolutely. So great question about coming off antidepressants. And in the deprescribing talk a couple months ago, I pointed out we have all these guidelines about starting treatments. If this person has this and this criteria, then you got to start them on this pill, or else you're breaking some kind of rule. We don't have rules about when to stop pills. Like there's 0 deprescribing guidelines. And the jury is really out about how long somebody should be on an antidepressant for if they had a positive response to it. So when I was in residency, just off the cuff, they would teach us, if somebody had a major depression, they get treated, they should be treated for 9 to 12 months. And then if they don't want to be on the pill anymore, they can come off it. But that may increase their risk of relapse. So the statistic that they taught was that if somebody has had 1 episode of major depression in their life, their likelihood of having another one is about 50%. Somebody's had 2 episodes of major depression, their likelihood of having another one's about 80%. If somebody's had 3 or more episodes of major depression, their likelihood is like 95%. So in the more episodes you've had that were treated, the more reason there might be to keep somebody on a medication to prevent future depression.
So you're saying episodes meaning you were treated, you came off of it, and then you relapsed.
Yeah.
Put back on again, and then came off of it and relapsed. That's what you're talking
Exactly.
about.
Yes. Yeah. So these would be with remission and then relapse. Whereas if just somebody had an episode of major depression and it got better on its own, does that mean they need to be on an antidepressant the rest of their life? No, that just doesn't make sense. So it's very difficult to study some of this stuff because you basically need alternate versions of the present where somebody did or didn't take the medication to know if they were going to relapse or not. But there is mounting evidence about discontinuation of antidepressants. Everybody's freaked out about that because, if somebody's got depression and then they get a little better and you take them off the pill and then they, commit suicide, was it your fault because you stopped the medication? And really, when it's studied more scientifically, it's clear that people can safely and effectively stop medications in a deliberate way and not increase their risk. All right. Well, thank you all for coming. Yeah, thanks.